Hi, my name is Linda Adouane. I'm a young reporter for the French Society of Gastroenterology, Pathology and Nutrition. It's my pleasure to be here at the 54th G.F.H.G.N.P annual meeting, and I'm with one of my friends that delivered a good speech, and it's a pleasure to be able to share with you the content of our amazing work.
Thank you, Linda. So my name is Charlotte Vergburt. I'm a medical doctor and a PhD student at Amsterdam, at the Emma Children's Hospital. And I'm doing research into pediatric IBD, and I had my talk yesterday here at G.F.H.G.N.P, which I was really nervous for, but it went very well, so I'm really happy. So what we did is, because we know that for pediatric IBD there's a really high burden and a high impact on health-related quality of life, but we still don't know really how to treat it well, because we know that the majority of children, they do not maintain remission with step-up or top-down induction treatment. So we are really needing better therapeutic strategies for these children to maintain them in remission. And so with all this fuss about the microbiome and it having a very big role in the pathogenesis and the pathophysiology of IBD, of course there's been a lot of research into the microbiome, but also development of different prediction models. So that is what we also did. So we developed a prediction model based on the microbiome. For this we used samples from the North American risk cohort, which is the biggest new onset IBD cohort in the world for pediatrics to date. And we had 197 available samples, and in the end we only included 42 samples because we really wanted the ones that were treatment naive, so the ones that had absolutely no kind of treatment when they handed in their stool. And we made a prediction model, and it's more like a community-based model, so there are a lot of prediction models out there in the microbiome that really focus more on specific bacteria and what the levels are, but this is more like a community-based model that really looks at the community of the microbiome, because we know that some bacteria, they really like to stick together. For some reason they're always together and they're always seen together, and this is actually a very important aspect also of the microbiome. So that's why we use this community-based model to predict treatment outcome at 1 year, so if children sustain remission or they do not. We made this model. In the end we had an area under the curve of 0.79, so 79% accuracy for prediction of remission or prediction of non-remission at 1 year. So what we also did is kind of like a little sub-study just to see, because we excluded so many children in our cohort because they had already started treatment, and this is actually how it works in clinical practice, because everyone forgets their stool or gets lost or whatever. So we used that stool and we looked at what happened with the prediction of the model if we ran those samples through our model. So we took children that handed in their samples within 10 and 14 days of starting treatment, and we saw that the area under the curve actually went down, but it didn't go as fast as we would have thought in the first place, if you think that some children had already 14 days of either antibiotics or steroids or immunomodulators. So we were very happy about that. And now next step of course is to do this into clinical practice, and ideally you would get a lot more samples to build the model on and to validate it, but I think the reality of pediatrics is that we cannot always have the high numbers like the adult research has. So we are actually using this now in clinical practice, or we're having a pilot trial where we are giving children that are predicted to be non-responders, we're giving them add-on antibiotic therapy, so they all get the Crohn's disease exclusion diet, and then they get add-on antibiotic therapy. And so we are really excited to see what happens, and stay tuned for the results.
Yeah, thank you so much for accepting to give the interview and make a small summary of your work. Thank you for the colleagues who unfortunately couldn't attend the meeting. And hope to see the rest of your conclusions then.
Yes, of course.
Thank you.